Welcome back to the deep dive. Today, our mission is pretty specific, actually. We're tearing through a whole stack of sources to figure out how exactly healthcare providers are getting trained to deliver, complex hospital-level care
Right.
safely and effectively. But when the patient's just sitting in their own living room.
Yeah, and this is it's an urgent field. It really is.
Yes.
Hospital at home or HIH. It's scaling up fast, both here in the U.S. and over in the U.K.
Right.
But the key thing, and our sources really hammer this home, is that HIH is fundamentally different. It's not just your traditional home health visit.
Okay.
And maybe the biggest gap identified right now is this lack of formal structured education, training that's specifically for managing acute illness autonomously in someone's home.
Okay, so let's really unpack that difference because, the medicine itself, right?
Yeah.
Treating the pneumonia, the heart failure, that's the same core skill.
Fundamentally, yes. The clinical knowledge is there.
But the environment, it just changes everything. You swap that sterile ward where everything's at your fingertips.
Yeah.
Right.
Resources everywhere for
the home. And like one expert pointed out, you just don't know what you're walking into. Could be super clean, could be, chaotic with a yappy dog.
Exactly. The yappy dog problem.
So the challenge isn't really the science, is it? It's more the professional prep, the emotional side of being truly autonomous.
That's absolutely right. The training has to drive this critical mindset shift. We need staff who aren't just competent, but are genuinely autonomous critical thinkers out there on their own.
So let's start with that basic challenge, the environment. In a normal hospital, risk is kind of standardized, controlled. What are the key differences when that clinician becomes, as one source put it, a guest in the home?
Well, it really boils down to two things: safety and resource availability. Simple as that.
Okay.
In the hospital, the institution manages the protocols, the environment. In the home, it's unknown territory every single time. And that clinician, they need the manners of a guest, like you said. They're stepping into someone's life. They have to immediately spot risks that just don't exist on a ward. Think throw rugs, bad lighting, loose cords.
Things that could cause a fall.
Exactly. Fall risks are huge, so training has to hammer home that environmental awareness, that safety management. That's job number one before anything else.
And that flows right into the critical thinking piece, doesn't it? When the immediate resources vanish, so does the reliance on quick tech fixes. In the hospital, you suspect something, you order the lab, the x-ray, boom, you get an answer fast.
Right. Almost instant confirmation.
At home, that speed, that proximity, it's just gone.
Precisely. You don't have radiology down the hall or the lab on speed dial, which means staff have to be way more judicious, more critical in what they order.
So it's not just inconvenient. It actually changes how they practice medicine.
It fundamentally changes it, yeah. And we found this really fascinating detail from David Levine's research. HAC-H patients, they actually end up having fewer blood tests than similar patients in the hospital.
Fewer blood tests. Now that sounds counterintuitive. Why?
Because the clinicians, they're forced to really max out their diagnostic skills, their physical assessment, before they use those limited resources, like, say, a mobile lab test.
Ah, okay.
Forces this cognitive shift.
Yeah.
You move away from just relying on the tech next door or grabbing a colleague towards making these really autonomous, carefully considered decisions, knowing that your backup is remote support, not immediate hands-on help. And that's a huge ask for staff trained in a big centralized system.
Wow, yeah. That really paints a picture of the mental load there. Okay, so let's pivot to solutions. How are some of the really established programs tackling this? Guys in St. Thomas's in the UK, they've been doing this for 13 years, hundreds of patients a month. How are they training their doctors?
Their model, it's really interesting. It focuses heavily on making this training mandatory and integrating it right into the career path for junior doctors, right after medical school.
Integrated how?
They designed this one-year rotation. It's deliberately set up to break down those traditional hospital silos.
Yeah, okay.
So it's 4 months doing hospital at home, then 4 months rotating through the hospital front door, usually the emergency department.
Right, the ED.
And then 4 months on a standard acute ward.
That rotation sounds pretty intense. Seems like it's really designed to force trainees to see the whole patient journey from ED admission right through to care at home and maybe back again.
Exactly. Connects the dots.
But 4 months in HAH, that feels quick to get someone truly autonomous for acute care. Did the sources raise any flags about that? Like, is it enough time?
It is fast, yeah. But the main goal there is that integrated exposure, understand the whole system,
Yeah.
Plus, they layer on specialized technical training.
Okay.
And the feedback, apparently, is that the trainees really value it,
Yeah.
especially the part about helping people stay home with their families while getting acute care.
So how do they mitigate that speed? You mentioned specialized training.
Yeah, they have this enhanced induction program called Sim at Home.
Sim at home. Tell me more. What kind of skills does a doctor need to do alone at home that maybe a nurse or someone else would handle in the hospital?
Well, they really focus hard on practical skills. Things often done by nurses or other support staff on the wards.
Like what?
Things like administering IV fluids, mixing complex 4V antibiotics, and crucially, using point-of-care tech, specifically the iStat system.
Okay, could you just quickly explain iStat for listeners who might not know that tech?
Oh, sure. Yeah. The iStat, it's basically a handheld portable lab.
Wow.
It lets the doctor take a blood sample right there in the home, run basic chemistries, blood gases, electrolytes, and get results in minutes.
Right there on the spot.
Exactly.
Uh,
So training on that specific device is essential. It directly replaces the central hospital lab for those key tests, but the doctor has to be confident using it, interpreting it, without someone looking over their shoulder.
That level of technical independence, just expected.
Right.
It's remarkable. Okay, let's shift gears a bit. From the doctor-focused adult care, let's look at pediatrics. Pediatric HA, like the PPCH service in Northwest London, started back in 2016. That's often nurse-led. How does that change the training focus?
Yeah, the pediatric model really elevates the nurse's role, their autonomy. So the training focus shifts significantly towards enabling really advanced nursing competency.
Okay.
These nurses, they have to make that same leap from a well-equipped pediatric ward to delivering acute care pretty much on their own, in a home, and often with worried parents, siblings around. It adds complexity.
So what kind of experience level are they looking for these very independent nursing roles?
The profile is definitely high. They're typically looking for experienced nurses.
Hmm.
The UK system, that's often band 6 level,
Which means?
which means they're experienced staff, intermediate or senior level, usually with 3 or more years of acute experience under their belt, often coming from acute pediatrics, the ED, or sometimes community backgrounds.
So what if they come from a community background that might be less focused on rapid acute assessment? How do they bridge that gap?
That's where the cross-training becomes absolutely vital, indispensable, really.
How does that work?
They have mandatory rotations built in. So, for example, a community nurse might rotate into the ED to really sharpen those acute assessment skills.
Oh, okay. Makes sense.
And conversely, an acute nurse might rotate out into the community setting to get a handle on the home logistics, the autonomy piece. And this is all built around standardized competency models, like the ones used in Northwest London.
Competency models.
Yeah, frameworks to make sure they methodically build the specific skills, the knowledge, and importantly, the behaviors needed for HAH. Often involves mentoring and support from doctors back in the ED or on the wards, too.
It really sounds like this whole effort, whether it's adult or peds, relies so heavily on sharing knowledge, sharing protocols.
Oh, absolutely.
Yeah.
It does. The experts we looked at really underline the importance of what they call a community of practice, especially across the UK.
Community of practice.
Yeah, sharing clear, agreed-upon protocols for common conditions. It's vital. Otherwise, every single team feels like they're constantly reinventing the wheel or like they're, quote, venturing into the unknown every time they scale up or tweak the service.
Which is just inefficient and probably riskier, too.
Totally inefficient and increases risk. Yeah.
That collaboration piece feels key for scaling safely. Okay, let's jump across the Atlantic now. Look at a very structured approach from Maribel Health in the U.S. They use this 4-stage blended learning framework. How does that kind of mandatory structure ensure the training is robust enough?
Well, they see the structured approach as like the bedrock of program safety and quality. It's non-negotiable.
4 stages, you said.
Yep. Stage 1 is didactic education. That's the theory foundation, delivered through e-learning, some in-person sessions. But crucially, they emphasize communication frameworks right from the start.
Why communication specifically?
Because in HAHC, coordination is everything.
Yeah.
Between the hospital team, the central command hub, the clinicians out in the field,
Yeah.
it has to be seamless.
Okay, so stage 1 is theory and communication. What's 2?
Stage 2 is skills training. More traditional hands-on practice, breakout sessions, mastering the equipment.
Standard stuff.
Pretty standard, yeah. Then stage 3 gets interesting. Simulation and role play. This is immersive, case-based learning, designed specifically to pressure test those complex workflows and build muscle memory for tricky situations.
Okay, simulation and stage 4.
Stage 4 is ongoing mentorship. This is key. It ensures the learning doesn't just stop after orientation. It means sustained support through preceptor coaching, at the elbow help initially, and continuous microlearnings.
That ongoing piece sounds critical. Let's dive a bit deeper into stage 3, the simulation. Given that the home environment is the big, unpredictable variable, how do you actually recreate that realistically in training?
Yeah, it's a challenge. They invest pretty heavily in what's called high-fidelity simulation.
High fidelity,
Yeah.
meaning,
Meaning they use carefully staged environments, mock home setups, and they often hire actors to play difficult patients, anxious caregivers,
yeah,
making the whole scenario feel as real and, frankly, as stressful as possible.
so they're simulating everything from the initial ED decision point.
Right. Through
Right.
to managing a patient at home who maybe isn't following instructions or whose condition changes suddenly. Yeah.
Do they have a specific simulation module for those environmental hazards you mentioned earlier? The rugs, the cords?
They absolutely do. One of the mandatory modules is called the What Do You See simulation.
Okay.
And the goal is simple. Clinicians walk into a staged home environment that's been deliberately seeded with hazards, loose cords, throw rugs, bad lighting, maybe even fake pets underfoot.
What?
They have to actively identify every single fall risk, every safety issue. Then they have to practice how they'd mitigate it, how they'd educate the patient, and document it all correctly.
So it forces them to think safety first, environment first, before they even get to the clinical tasks.
Precisely. It reinforces that pillar. Assess and manage the environment before you proceed with care.
That's such a holistic view. It recognizes that the training isn't just about the clinical boxes you tick, but the art of managing the whole context.
Exactly, the art versus the science.
And one of our sources suggested that art, the patient approach, the relationship building, can sometimes be the make or break factor between a program that's struggling and one that's really taking off. How does coaching help drive that success?
We found a really powerful case study on this. It's from a Midwest health system in the U.S. Their H program was about 14, 15 months old, but is really struggling to scale up.
Struggling how?
The critical bottleneck was getting patients admitted from the emergency department. Only about 20% of their admissions were coming from the ED.
And just remind us, why is the ED so crucial for HH volume?
Because that's where the acutely unwell patients show up first.
Right.
The ED team has to make rapid decisions. Does this patient need an inpatient bed? Or could they be suitable for hospital at home? And if the HE team isn't really skilled, really confident in communicating their value proposition, quickly screening patients,
Then the ED defaults to the familiar option.
exactly, they'll just admit the patient to a traditional ward bed. It's safer, it's faster for them if the HEH process feels clunky or unclear.
Okay, so they had this bottleneck. What was the intervention? What did they do?
They brought in specialized help for 8 days of intensive personal coaching and mentoring for the HE staff.
8 days. Focused on what? Clinical skills?
No, not clinical skills primarily. The focus was entirely on improving the staff's approach, their communication, how they educated patients and ED staff about HEH, how they built relationships and trust right there in the busy ED environment.
So boosting confidence and communication effectiveness.
That was it, making them better ambassadors for the program, essentially.
And what happened? What were the results after just 8 days focused on those, quote, soft skills?
The results were, honestly, immediate and pretty dramatic.
Hmm.
Over the next 2 weeks, their average daily patient census nearly doubled. It jumped from 5.2 patients per day up to 9.12.
Doubled. Wow.
And that key metric, ED admissions, it shot up to over 50% of their total volume, way up from 20%.
Incredible.
The coaching directly led to 21 more patients being admitted to HERH in just those 2 weeks than their previous run rates suggested.
21 more patients in 2 weeks, just from changing how the staff communicated and interacted, not changing the core medical model itself.
Exactly. It's a huge lesson, isn't it,
Yeah.
about where the real levers for scaling might be.
Absolutely huge. And what about the financials? Was there an impact there?
Oh, highly significant. And the data point here really connects the dots between investing in coaching and the bottom line. Each of those extra patients represented an average DRG payment of about $9,500.
Okay, quick definition for our listeners, DRG payment.
Sure. DRG stands for Diagnosis-Related Group. It's basically the fixed amount of money the hospital gets reimbursed, usually from insurers like Medicare, for treating a patient with a specific diagnosis.
Got it. Fixed payment per case.
Right. So admitting those 21 extra patients, that generated roughly $200,000 in additional revenue in just 2 weeks.
Wow.
It's a pretty tangible demonstration of the ROI on mastering those seemingly soft skills.
Seeing numbers like that really validates investing in, well, human behavior and effective communication, doesn't it? Not just clinical tech. Okay, as we look towards the future then, what technologies are people talking about? What's poised to define the next generation of HAH training?
Well, the sources pointed towards a few key areas. One is leveraging adaptive learning platforms, much more.
Adaptive learning.
Yeah, platforms that can actually personalize the education, tailor it based on an individual clinician's specific skill gaps, their learning pace, make it more efficient.
Okay, makes sense. What else?
There's also huge excitement, understandably, around virtual and augmented reality, VR and AR.
For simulation.
Exactly. To really enhance that simulation experience.
Yeah.
Imagine letting clinicians practice complex scenarios or maybe rare complications
Correct.
over and over in VR without needing actors or physical setups.
Yeah, I can see the power in that. Repetition without resource drain. And looking even further out, what about AI, artificial intelligence?
AI is definitely on the horizon. It's often envisioned as a potential kind of real-time co-pilot for the clinician in the field.
A co-pilot? How?
Well, imagine AI coaching tools that could provide instant feedback, maybe decision support, to clinicians working alone in the home, helping them feel less isolated, maybe double-checking things, helping maintain those really high standards needed for acute care.
That's fascinating. Okay, so if we try and pull all this together,
Right.
everything we've covered, from the need for sharp environmental awareness in the UK models to the structured blended learning and simulations in the US, and that powerful impact of coaching. The main takeaway seems really clear. Training for hospital at home, it has to build more than just advanced clinical skills. It's got to forge this fierce autonomy, environmental mastery, and super effective, reliable team coordination.
Yeah.
It really is about empowering that one clinician to make the right, often high stakes, call when they're literally the only healthcare professional in that living room.
Beautifully put. And this focus on the clinician as the ultimate autonomous decision maker, it raises one last kind of provocative question that came up.
Oh.
One expert noted that HAHC, quote, isn't for everyone. It's like Marmite. You either love it or hate it.
Okay, I get that divisive flavor.
Exactly. It implies it takes a certain disposition, right? So given these intense demands for adaptability, independence, problem solving on the fly, what personality traits, what soft skills, beyond the clinical degrees, what will become the most critical criteria for actually recruiting people into this rapidly scaling sector in the future?
That is a great question. Something for you, the listener, to chew on as you digest this deep dive. If you had that magic wand for HAH education, where would you put the resources?
Advanced mentorship, AI coaching, those VR adaptive learning platforms.
Essential questions, definitely. Especially for a future where the hospital itself is becoming less of a building and more of a service delivered anywhere.
Absolutely. Well, thank you for guiding us through these really critical sources on the future of acute care training. It's been fascinating.
My pleasure. Always interesting stuff.
Well,